Excellent. Thank you so much. Hi, everyone. My name is Ayesha Azam. I am the Vice President of Medical Affairs at the Patient Access Network Foundation, and we're so happy that you were able to join us today to talk about our panel. I'm joined by Clorinda Walley, who is President of Good Days Foundation, and Gerald Loria, who is the Senior Vice President of Business Development and Strategy at the Assistance Fund. We're excited to talk to you today about some of the challenges in navigating the complexities of patient assistance. We were so thrilled to have heard from our other partners this week, Excelsior Health, Healthwell Foundation earlier today, and there's so much knowledge that all of us have in this space. And thank you to the Healthcare Advocate Summit team, Elizabeth and Melissa especially, in bringing us all together and allowing us an opportunity to talk about our passions. Clorinda, would you mind telling us a little bit about yourself and your organization?
Oh, sure. I work for Good Days. I've been with the organization. It'll be 15 years on October 15th, which is kind of crazy.
Wow.
A lot has changed in the manner in which we help people and the bridges that we're trying to help them cross. So previous background was in retail pharmacy, specialty pharmacy, and then Good Days. It was nicer to be on the end to tell someone I can help them than deliver the $10,000 copay, and hearing kind of the loss of hope when they realize that I just got diagnosed, there's a treatment that can help me, and it's not reachable. So that's a little bit of my story.
Is this on? Okay, good. Gerald Loria. I've been with the Assistance Fund actually, I think tomorrow is September 9th, right? Yeah, so tomorrow is my 9-year anniversary. Yeah, so before that, my background is commercial side of pharmaceuticals for, I don't want to say because I'll give my age away, but it's been a long time. And it's been great at TAF. We were founded in 2009, and it's just really amazing. I never dreamed to have this job and to help patients. It's really been so rewarding. And I hope for another great 9 years. So,
that's excellent. Thank you both for sharing. I've been with the PAN Foundation for about 7 years now. My favorite part of what we do is that we can help more and more patients every single day. I came from the Cystic Fibrosis Foundation, which is a phenomenal organization dedicated to a single disease. And I remember still when I came to PAN, I was amazed how we could have a reach in the same way in across 50 diseases, 60 diseases, and now we're at 70 diseases and able to help so many patients around the country. So with that, we'll go ahead and dive into our panel.
Yes.
So really what we want to start with today is talking about some of the challenges and some of the opportunities that face us as we consider charitable assistance and look at opportunities. One of the most recent items in the space relates to advocacy. Charitable patient assistance foundations are a critical safety net for patients who have no other means of covering their out-of-pocket medications. In August, President Biden signed 4 key Medicare reforms into law through the Inflation Reduction Act. Legislation that will make prescriptions and vaccines affordable or more affordable for 49 million people with Part D coverage. This legislation includes, for the first time ever, an annual limit on what Medicare beneficiaries will pay out of pocket for their prescription medications, and beginning in 2025, people on Medicare will spend no more than $2,000 per year out of pocket for their prescription medications, and they will have the option to pay monthly tandemly provisions commonly referred to as cap and smoothing. So they do not have to pay exorbitant amount of cost at the beginning of the year and have to pay less throughout the rest of the remainder of the year. When we think of these provisions, Clorinda, if you would like to begin,
Sure.
What do these provisions mean for patients and what is the impact to them?
I think, again, the reason why we all exist and why we're here is to bridge those financial gaps. All of our foundations were created to ensure that people will never have to choose between, paying their bills, getting food on the table for themselves, or affording their prescriptions. And what I think this is going to do, again, it's going to provide coverage to the entities in this country that need it the most, which is our elderly population, which is only continuing to grow. I also hope that it will then allow us to help more people. What I would really hate to see is that the donations decrease because the out-of-pocket costs cap goes to $2,000. As you all know in this audience, and many of you have voiced those concerns to us, is, why does the multiple sclerosis programs across all of us open and close? Why are so many programs, closing more often than they're opening? And what I hope that this will do is ensure that the donations are still coming in and just allows us to help many more people, those who are not receiving assistance today because these programs are closing.
Yeah, that's a great point, especially because it's going $2,000 a cap is great because today people are spending $5,000, $10,000. But as we were talking earlier, this is only effective for Part D medications. So for Part B medications, infusions, dialysis, it's not affecting that. There was still no cap 20%. For those areas.
Yeah, so to piggyback on Clorinda, we look at it's amazing, right? I never thought it would happen, but it happened, and to have, because we see patients that they have to make that decision. Do I eat? Do I pay my? Is that me? I'll sit back. If that's me, or do we put food on the table, or most importantly, do they take their treatment? We see a lot of patients that are diagnosed with very serious diseases and they just simply can't afford the medication. So we look at it, the most important thing is they'll be able to stay on their critical treatment that they need, but then also hopefully that we can help more patients, because we see patients with out of pockets, and when I heard some figures, I'm like, oh no, that's before the script has to be adjudicated. They're like, no, that's their out of pocket, and I can't even imagine, even if you're in your peak financial earning years, you can't afford this medication, let alone our Medicare beneficiaries that are on a fixed income. So we think it's amazing, and so we're looking forward to it.
How do you see the need for patient assistance shifting as these provisions come into play? Do you feel that the need for patient assistance will increase, decrease, or stay the same?
So, you want to?
No, you go.
Okay. So, the need is far greater than all of the dollars that we have put together. I don't see that shifting. Again, our population is getting older, so you're going to have a larger number of Medicare recipients. So I certainly think the need is going to stay where it's at. However, I hope again, if we can then take the expansion of our dollars. So for example, if we're treating somebody or providing financial assistance to somebody who has multiple myeloma, and we're helping them with about $6,000 to $7,000 a year, and we can reduce that to $2,000, how many more people can we help?
Yes.
And so, I truly hope that this provides us the opportunity to extend assistance to those individuals who aren't getting it today because the funding has run out.
Absolutely. I mean, the need is never going to go away, right? The need is always there. And if you look at patients, no one's going to say, okay, my out-of-pocket was $8,000. Oh, now it's only $2,000. I don't need to be in Good Days or TAF or Healthwell or Penn. No, they're going to still need assistance, and that need's never going to go away. So we hope that funds will stay open longer because we can help more patients, that the financial burden is not as great, but it's still a financial burden. $2,000 is a significant cost, especially for our elderly population. Yeah. So,
and when you're looking at the types of conditions in which we provide assistance to, that's not even taking into consideration the medical costs. So again, when you have to cover 20% of a hospital bill or 20% of an infusible product, it's hard to afford. And I've said this before, and many of you might have heard it, but as I've gone to my financial advisor and I'm trying to figure out how much do I have to save for retirement, no one has ever sat down with me and said, okay, do you plan on getting cancer or not? And so that's where we're at. If people paid their taxes, they did everything right, have some savings, but not enough to live and to afford these types of treatments so they can continue living.
Completely agree. The cap is only still for prescription medications. If someone is having financial toxicity, it doesn't mean that it's limited to just one area of medical or healthcare expenses. There's other social drivers of health, as we heard in the health equity talk an hour ago. There's a ton of different challenges that everyone must go through to make sure that they're receiving equitable care, and that goes with the cost as well. There are 8 charitable patient assistance foundations that are regulated by the Department of Health and Human Services Office of Inspector General. the OIG has issued advisory opinions to each of these foundations to provide guidance on how we must operate. There are similarities and differences, such as we all must serve patients on a first-come, first-served basis. And then there are some differences in how we can, for instance, such as how we design the list of medications that we cover. So let's talk about those similarities and differences more in detail. Clorinda, would you like to begin? What are some of the other similarities or differences across foundations?
You know, I think with the latest opinions, I think it's kind of level set all of the different things that we have to do. But, you know, for an example with Good Days, and I think it's really across all of us, you know, formularies aren't decided by me. They're decided by our medical board and a third party who kind of just reviews it. For Good Days, we cover any treatment that's FDA approved for that specific diagnosis. Is that the same for?
Yes, we're FDA approved.
And what about PAN?
We cover all drugs that are FDA approved, as well as those that are guideline recommended or compendia listed. I also know like another foundation, Patient Advocate Foundation, they also cover drugs that treat symptoms and side effects for all of the diseases that they offer. So it varies by foundation, and so it's incredibly important to look into what each foundation covers to find out which one will best serve your patient's needs.
Mm-hmm. And across all of ours, you'll find it on our websites by category. What is covered under each program.
Completely.
And you know, I'm looking across, I think I heard earlier from HealthWell having an opinion that can do Medicare only, but I think that we all have programs that are some that are just Medicare only recipients, or at least government funded. Mm-hmm. So whether it's like military, Medicare, Medicaid, and I'm trying to think, I think from a financial perspective, all Good Days programs follow the same financial guidelines, which is 5 times federal poverty level or below, and that is set by the board of directors.
I was going to say with the similarities, I mean, there's 8 of us now. You know, we're all amazing organizations that are here. Our ultimate mission is to help patients. So the similarities, again, you may look and say, well, you know, I was diagnosed with melanoma, and there's like 5 funds with melanoma, right? So there's always, especially in the oncology funds, there's going to be 4 non-small or 5 non-small cell lung cancers, you know, renal cell carcinoma, all these. So there's a wide variety of options. But again, we all do wonderful things. Again, the assistance fund is specifically FDA approved. And yeah, again, following the opinion. I thought I was going to go into differences, but I think that's your next question.
Go ahead.
Oh. So there are some slight discernible differences. In particular, the assistance fund, we go off of a calendar year. I know some others do, and others do a rolling 12-month. That's just, you know, how it is. We just got to make sure there's money there from when we re-enroll patients from Q4 going to Q1 of the subsequent year. And then in terms of grants, we actually don't do grants. We don't have caps. So we use a modeling where we can determine the financial need of the patient for that year. So that's a good thing. Patients come in, they don't have to worry about if they're going to be funded throughout the year. So I think, you know, there might be some others, but off the top of my head, I think those are, you know, again, slight. I mean, all the charities are wonderful, so.
Yeah, I think that's a great one. Another similarity is who can apply for assistance. Across most of the foundations, patients, their caregivers can apply on behalf of themselves. Healthcare providers and pharmacies can also apply on behalf of the patients. Pharmaceutical companies and their affiliates cannot apply on behalf of anyone. That's pretty standard across the foundation. Mm-hmm. Another standard item or similarity across the foundation is how donations work. When donations come in, they can be earmarked for a specific disease. They cannot be earmarked for a specific drug. And so what that means is you might see some disease programs or assistance programs that are open all year long and others that are open only for a day in the entire year. And that can be really frustrating to try to find assistance. But I think what every single foundation tries to do is try to keep their funds open as long as possible. And they do that through a variety of mechanisms, which could be narrowing the eligibility criteria or looking at the eligibility criteria to serve patients who may not be able to get assistance elsewhere. Looking at the type of assistance offered. So I know at PAN, we offer 3 main types of assistance. We offer copay assistance, which covers deductibles, copays, and coinsurance for prescription medications. We offer premium assistance for some of our diseases, and then we offer transportation assistance, which is an add-on service for anyone getting copay or premium support from us. The way that we decide how much assistance we offer in our programs really goes back to us going back to our populations and understanding what types of claims are people submitting, how much is going to be enough so that we can cover the majority of their assistance in one grant. So our goal is to not to have everyone come back to us to get additional assistance, but that first grant that they get is sufficient for a 12-month period. Clorinda, how about you? What does Good Days do?
Yeah, we'll look at the category and all the possible treatments and combinations that an individual can take, and look at, what is the maximum dollar amount that an individual will need to get them through coverage, and we are a calendar year program. And so that's where we'll set the cap. And then from the types of programs, again, very similar, we do financial assistance to help cover medication costs or treatment costs. We do travel assistance, premium assistance, and we also do diagnostic assistance.
That's great.
So at the Assistance Fund, we do copay, which goes in co-insurance. We also do health insurance premiums. And then for our rare disease funds, we do incidental medical expenses. So that can be including travel, infusion costs, nursing services, genetic testing. Again, we were talking before, there's other out-of-pocket burdens, just not on the actual copay of the drug. So, yeah.
Okay, that's great. I think, Gerald, you were mentioning that at the Assistance Fund, there's no limit to the amount of assistance that you provide patients. So I think this next question may not apply to you, but, what can advocates do if the amount of assistance they receive is not enough for the patients? Does that occur at your foundation at all?
No, once you're in the program, they're covered through the end of the year. But, if the fund's closed, and that happens, again, melanoma, we work, again, in unison, and the ultimate goal is to help the patient. So if we're closed, and let's say our melanoma is closed, but HealthWell's open, we'll send them to HealthWell. If our renal cell carcinoma is closed and PAN's open, we'll send them there, and I know they do reciprocate. So, but during the year, no, they wouldn't fall short.
Okay, and we began touching on this, but Clorinda, why do foundations open and close so often, and what can advocates do when that happens?
Well, so, again, we depend upon donations. And, as much as we ask, and I assure you, none of us have a problem asking for money to ensure that we can help the people that we serve and hopefully increase the number of people we can help. But if the donations do not come in, our hands are tied. And it's not because we don't want to. It's also not that we select it. When we're going and we're soliciting dollars, we're knocking on every possible door. And so from an advocate's perspective, what can you do is it's what you're already doing on behalf of your people. Make noise. Start talking about it. Talk about the need. And we're asking dollars from every entity in healthcare available, pharmaceutical companies, JP Morgan. We're knocking on every door, any entity that has a giving arm. But I think that the biggest thing we can do is work together as a community and voice the need.
Definitely agree. There's definitely some levels that each foundation has that can be taken advantage of to learn about when foundations open. Half of the foundations have a wait list, which allows you to apply your patients or add your patient to that list to get notified. Some foundations have, HealthWell was mentioning earlier today, they have real-time fund alerts, which will notify you. The PAN Foundation a couple of years ago put out a free web app called Fund Finder, where you can sign up and get email and text message alerts when disease funds open across any of the 8 Charitable Patient Assistance Foundations.
I love that, by the way.
Thank you. We love that, it's not only providers and pharmacies that use it, but that half our users are patients themselves. And so our ultimate goal across the board is to make sure that across every foundation, and I think that we can all say that, is that we want to get everyone help when they need it as soon as possible.
Yeah, and one of the things that I think outside of this, I know that there are so many different needs, and I think that one of the key things that we do is we try to partner with other advocacy organizations that are outside of financial assistance. So for example, cancer care, they have a vast a bucket of resources for people, let's just say, suffering with breast cancer, prosthetics, wigs. There's like all these different things. So when Good Days can't help them, when Assistance Fund or when PAN or HealthWell, there's a variety of other organizations that can help bridge some of those gaps. So even let's just say that there's not assistance available financially to help cover medication costs. If we can cover travel costs or cover the cost of a prosthetic or a wig, those types of things, any way that we can offset medical expenses or expenses just provides that much more opportunity for that family to survive.
I just wanted to mention when funds open and close, when a fund opens and then you set a day, and it does happen in some disease states, and then it closes, know that those patients are running their full grant or the 12 months or across that calendar year. We're not terming patients. So I know it gets confusing because people think, oh, the fund was open and it's closed, and now I might lose my assistance. You're good for whatever foundation you're in through the year or the 12 months or as long as the grant lasts. And there are funds that do open and close, unfortunately, very quickly. But that just shows you how great the need is.
Definitely. Gerald, what would you say in how can healthcare advocates identify their patients or evaluate their patients' needs and identify the best foundation for what their patient needs?
Yeah, so I mean, I think the most important thing is you choose the foundation that has the disease state, right? So you may say, oh, I've heard great things about PAN, but they may not have the disease and the disease state. So I think you look at that, and as I mentioned, there's a lot of overlap. I think a lot of the charities have it. I think every disease space has, there's at least 2 to like 5. So I would choose the one that's open. That's always good, so you can get assistance. But obviously, you know, evaluating, again, I know every one of the charities, and I think we all get along. We all have a mission to help patients. So I think they're all great. They're all good financial stewards. They all follow their OIG opinion. They want to be compliant. And they want to do what's right. But again, I think getting into the fund that's open is paramount. And I think they all do a great job. And again, the most important thing is that the patients will have access to their critical treatment, that they can, get healthier and be good.
Clorinda, anything to add?
No, I agree. And again, the one varying factor is make sure that the product is covered, because again, at Good Days, we're only covering FDA-approved therapies. So we don't do off-label, we don't do compendia, where PAN does. And I think, what was the other organization?
A Patient Advocate Foundation.
Patient Advocate Foundation, who not only covers indication, compendia, and others, they also cover dependent meds or medications that go along with but aren't exactly treating the disease.
Agreed. I think another factor is looking at the policies that the foundation has and what are those support services. So if your patient needs transportation assistance, perhaps PAN is a good option for them. Whereas if they also need premium assistance, perhaps HealthWell is a better option for them because they can alternate back and forth between copay or premium. Or perhaps if they need ancillary medical expenses, Accessia Health is the best option. Mm-hmm. So looking at support services that the foundation provide is key. The second factor could be look-back periods. A lot of foundations offer a look-back period that will allow you to cover past due medical bills. So for PAN, it's 90 days. For other foundations, it could be 30 days or 6 months. And so that might be another factor that affects it. The amount of assistance might be in one. If there's multiple foundations open, and you have 10 patients to apply, you might find that there are some patients you're sending to one foundation versus another because you know what the annual out-of-pocket cost is going to be. So that's a lot, right? How do you think, Clorinda, advocates can manage all that, knowing that there was a ton of foundations out there, there was a lot of different rules, and foundations open and close quickly? I
really like your fund finder. So that's always a good tool. And it is difficult. I mean, you've got several different organizations, and we all have different portals. But we do try, and every one of us has a list. If you want to get on to see, we can email you or correspond letting you know what's open and closed. But another thing that you all can do to help us and to help protect your people is like just looking at Accessia Health and what Gwen had to say. There's a lot of legislation and policy out there that can help guide, protect, and ensure coverage for all of the individuals that we're trying to help. Is so supporting us on those ends. and ensuring that, you back us. It's easy for me to go to one of my congressmen or senators and talk about what I think the public needs. It's a much stronger voice when you have, a room full of their constituents. So, not only are we trying to help the individuals, but a way that you all can help us is by looking at those things and seeing what we can do together to make a difference in these patients' lives.
Definitely. At this point, we're happy to turn it over to questions. If you do have one, feel free to raise your hand and we'll be happy to pass the mic to you. Yes, go ahead.
Do you think that it would be beneficial if you could put a way that if a patient is approved for a grant for, say, $6,000, and the patient isn't going to use that full $6,000, that when the patient's maxed out of pocket has been met or something else happens, and the patient doesn't need the rest of the funds, that you could be notified so that those funds can be allocated to someone else?
That is a wonderful idea. It's something that we've actually talked about before, I know at least at PAN. And one of the challenges that idea can pose, which is a wonderful idea, it goes back to our advisory opinions. So advisory opinions across the board are very specific that we cannot create policies or procedures that are dependent upon a drug that someone is taking. And so ultimately, in that case, sometimes what can happen is if we were to give someone a $6,000 grant and then cut it off at $4,000 before their year ends, because we know that's all they're going to use, a potential challenge could be then, well, what if they switch drugs? Or what if they decide that, what if that case becomes drug specific? And so I think it's a great idea to maximize assistance. I think that from a policy or procedural point, we would have to challenge that with regulations that are placed upon us.
And
you have patients going on hospice, no longer having treatment, and every day the reality is that patients that are enrolled or actually passing away, their treatment isn't happening, notifying us that this patient no longer living.
Yes.
But it is, and so one of the ways that we do it is when we're looking at how much funding we need to help an individual, we're not looking at, okay, every individual's going, let's just say the grant just for easy numbers is $10,000. We're not saying, okay, 10,000, 10,000, 10,000, 10,000. We have algorithms and companies out there that are looking at dollars and saying, okay, even if every patient is getting an up to $10,000 grant, on average, they only use $4,200. So we're really only allocating in real dollars the $4,200 across the board. So at Good Days, I know in let's just look at macular degeneration. Although the grant is up to $6,000, average utilization across the board is $1,300 across the board. So that means the people who apply for assistance and use none of it, the people who apply for assistance and use the whole amount, or the people that apply for assistance and use $4,000. I've got 10 years worth of data to tell me exactly how much is actually going to be utilized, and taking into consideration the different products that are coming to market, price increases. So in reality, it's not money sitting in the bank waiting for nobody to use. We have a very specialized math and algorithms that are going on so to help us effectively utilize these dollars. I mean, we have a fiduciary responsibility. We can't be sitting on, hundreds or millions of dollars that aren't being used. So the reality is, although it looks like the dollars are sitting there, we understand what is actually going to be used and what can be turned back. One of the things that Good Days does is we'll look at the last 90 days. If we haven't seen a dispense in the last 90 days, depending upon the disease category. So if it's a disease category that's highly dependent upon Part B, so the 20%, we do a 5-month look back. If I haven't had a dispense or a service request for payment in 5 months, we close the account and move on. However, if the person comes back just because, let's say, the doctor was late on billing or something, it will just open back up. But again, I think that we all do a very good job from a financial perspective of ensuring those dollars are utilized to the maximum ability, not to mention the fact that we're audited annually to ensure that those things are taking place. Oh, no, yeah, I was just like, but yeah, so the money is never truly just sitting there.
Us, we're similar because we don't have the grant, so we do look backs, and if, again, therapies are on different administrative schedules, but if we see basically, let's say it's a daily medication, and this patient, again, these are very serious life-threatening diseases, they haven't taken their medication 90 days, we will reach out, and if we find out that patient, for whatever reason, no longer needs the assistance, we will immediately put that back into the pot.
Rotation.
So, yeah.
I see a question over there.
I know.
Hi, I'm usually pretty loud. Do you ever go outside the box? Our organization, we're a nonprofit, and we train family members and caregivers to be patient advocates. Sometimes they turn professional. Do you go outside of what you usually do? Because we've never been able to find funding for this. We've been doing it for 25 years. And it's really, we do it on a small scale, but we want to grow this so people can help people. And our focus is on safety. So teaching people about safe medication use for their family members would be part of it. Is this something that you've thought about, or is possible even to go that way?
So from a Good Days perspective, we don't have trained counselors. And so that's nothing we've ever considered, because there are so many great other organizations out there that do it. And so when we find somebody that needs a different type of support, whether it's psychosocial or a different type, we will then try to turn to another organization who has those resources. It's not something we've considered, because I think it would be very difficult, hard to do.
Yeah, so another stipulation in all of our advisory opinions is that patients must have the freedom of choice to choose their drug. And so we have made the decision, just to stay on the safe side of that we partner with leading national patient advocacy organizations, and we connect our patients with them to talk specifically about disease information. And so that's the extent that we've been able to do it so far. But thank you for that suggestion about drug safety, because certainly as we're supporting patients with prescription medications, that's certainly a very critical component. One last question, and then I think we'll have to conclude.
Just in anticipation of the 2025 Medicare changes, do you expect to have that impact the eligible incomes of patients and the percentage of FPL?
Could you speak a little louder? Sorry, we can't hear you.
So sorry. With the upcoming 2025 Medicare changes, do you anticipate those changes impacting the qualifying incomes for patients, the eligibility criteria?
From Good Days' perspective, no. Again, there's far more people out there that need help that we have to turn down because there isn't assistance available anywhere. And again, on average, the people that we support make less than $39,000 a year.
Yeah, same. I'm looking, it's like the Oscars. It's been...
the lights are so bright, it's hard to see.
Zeros for a while. Yeah, we can't see anything. I'm blinded. I'm going to need to see that retinal specialist.
At Penn, I also don't think we would, it would ultimately result in a change to eligibility criteria. Clorinda, you mentioned on average, the population that we're supporting is Medicare beneficiaries whose FPL or federal poverty level incomes are at or below 250% of the federal poverty level, but we go up to 500%. And so what I do see happening is what Clorinda was talking about is an increased need. Like as she mentioned, there's a ton of people out there who don't even know charitable assistance exists, who have tried to get charitable assistance and they can't because disease funds are closed. And especially with the COVID pandemic, there was a heightened scrutiny where the conversation of financial toxicity is much more prevalent than it used to be. And so I think every single year, there's going to be an uptick in the number of people looking for assistance. And so even with those levels happening where a cap is going into effect, I think there will still be a continued need for assistance, and the Medicare plan design will need to have much more significant changes in order for us not to have to rely on foundations like us anymore.
That is correct.
Charitable foundations really are often the only place where low-income Medicare beneficiaries can find assistance to start and stay on treatment. Across the charitable foundations, across all of us, we help nearly 500,000 people, but there still remain 44 million people on Medicare, and more than half of these folks may qualify for assistance. Ultimately, the safety net is not big enough. As a parting, Clorinda, what would you say that healthcare advocates can do to raise awareness about the out-of-pocket burdens that patients face?
again, most of your jobs is trying to find that path on behalf of the individual. And you're going through that journey, you're doing the benefit investigation, you're determining that, the amount that the patient has to pay is insurmountable. They can't make that. You're reaching out to all of us. And again, the biggest thing you can do is use your voice. When there isn't funding, you tell everyone around you, we need funding for this, we need help for this. And we're already knocking on doors and saying the same message. So I think that the more we talk about it and the more we realize that, there is a lot of financial toxicity when we're looking at the types of diagnoses in which we're providing assistance to.
Yeah, again, be the patient voice. I know seeing you guys today and in other conferences, I mean, you guys, you don't take no for an answer, right? You're fighting for the patient to find that financial assistance and fight for them. So continue to do that because, again, the financial toxicity isn't going to go away. And advocate, you were mentioning, DC legislation, advocate for pro-patient policies, at the state and federal level. And we appreciate all that you do.
Yeah.
He's ready to kick me off, so I'm just looking over.
Well said.
Not at all.
We're keeping you from happy hour.
Well said. I think that it cannot be understated or overstated enough to share your story. It's tiring sometimes. It's exhausting. You're trying to do 12 different things and help a ton of patients, and being able to share your story is just another thing on top of that. But continue talking to everyone talk to your field reimbursement counselors, talk to other advocates in the space. Continue to come and be present at conferences like this and let us know as foundations what we could be doing better and where you see gaps within the environment so that we can also continue to step up and be there for what you need. We are all in the exhibit hall and we'll be there tomorrow, so feel free to reach out to any of us if there's anything we can provide or support you with. Thank you so much for your time and hope you enjoy the rest of the conference.
Thank you.
Give it up, give it up, give it up, give it up! Thank you guys so much. Please be careful.